So I welcome you all to yet another session of the Residence Corner module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital. Today we'll be discussing the anatomy of third ventricle. Dr. Amna is here to residents neurosurgery. Dr. Amna, can you please start your presentation? And Dr. Ariba will follow up with the clinical part. So Dr. Amna will present with the anatomy, and then Dr. Ariba will discuss a few clinical points related to the third ventricle. Dr. Amna, please start your presentation.
Assalamu alaikum. Is my voice audible?
Yes, Dr. Amna, it's audible. Can you move your cursor and just make sure it's visible? Yes, it is visible.
Sir. Okay, now we will discuss regarding the anatomy of the third ventricle. Previously, we have discussed anatomy of the lateral ventricle. Now we all know that the third ventricle is a single structure which is located between the cerebral hemisphere. It is connected to the lateral ventricle by the two foramen of Monro, and it is connected and posteriorly it is connected to the fourth ventricle by the cerebral aqueduct. The third ventricle is a narrow funnel-shaped unilocular midline cavity. It communicates at its anterior superior margin with each lateral ventricle through the foramen of Monro, posteriorly with the fourth ventricle through the aqueduct of Sylvius. Now we will discuss regarding the boundaries of the third ventricle. As you can see in this diagram, there's this green color structure which is shown is the fornix, which form the roof of third ventricle. The fornix separate the third ventricle from the lateral ventricle and septum pellucidum. The red color structure, as it is shown in this diagram, is the anterior border of the third ventricle, which is formed by the anterior commissure and the hypothalamus sulcus. And anteriorly, it is also formed by the part of the lamina terminalis. The inferior portion, as you can see in this diagram of the third ventricle, it's formed by the optic chiasm, which is followed posteriorly by the infundibulum recess and tuber cinerum, and also posteriorly by the mammillary bodies. The posterior part of third ventricle is formed by the hippocampus commissure and habenacular commissure and suprapineal recess and pineal recess. And posterior inferiorly, the aqueduct is present, which connects third ventricle to the fourth ventricle. Now we will move forward to look each diagram step by step. The third ventricle has total 5-part: roof, floor, anterior wall, and the posterior wall, and the 2 lateral parts, which coincides with the thalamus. And in the center, there is the massa intermediaris. This is another diagram which is showing the third ventricle relationship with the corpus callosum and the septum pellucidum. As we can see that the superior floor or the roof of the third ventricle is formed by the septum pellucidum, and above the septum pellucidum corpus callosum lie. And posteriorly, as we can see that the vein of Galen is present at the posterior part of third ventricle. The vein of Galen and the central vein joined to form the internal cerebral veins. And anteriorly relationship, as we can see in this, it is relationship with anterior circulation. Inferiorly, you can see its relationship with optic chiasm, and here we can see the optic nerve. The floor, which is related with the midbrain, and posteriorly, as we can see, there is the quadrigeminal system. Now, this is another diagram which is showing a mirror, a view in which we are seeing from medial side to the lateral side of the third ventricle. As we can see that the superiorly the floor is formed by the body of fornix, and below the inferior part of the body of fornix is formed by the velum interpositum. The floor of a third ventricle is a it consists of three structures. The one is the neural structure and two is the vascular structure. The velum interpositum has two parts. It's consists of internal cerebral veins and medial posterior veins, and the part of the velum interpositum which is inferior is relationship with choroid plexus. The superior anterior part of the third ventricles form the foramen of Monro, which is the crescent-shaped structure, as we can see in this diagram. The boundaries of foramen Monro is anteriorly, the anterior part of foramen of Monro lies with anterior commission, and posteriorly its posteriorly its relationship with body of fornix, and superiorly with the choroid plexus and velum interpositum. This is the anterior part of the third ventricle, in which we can see the anterior commissure and the lamina terminalis. Anterior-inferiorly, as we can see, that is a chiasmatic recess and chiasm, and this is the here it is relationship with optic nerve. Inferior part, it is formed by the infundibular recess, and as we can see, it's inferior. The floor, which is inferior posteriorly, is relationship with midbrain, in which we can see the cerebral aqueduct. Posteriorly, we can see the posterior commissure and the pineal gland. Now, this is another diagram in which is showing the relationship of fornix with the third ventricle. As we can see that the body of fornix continue and divided into two fornix commissure, which runs in anterior lateral and in inferior direction, and forms up to the floor of the third ventricle and reach to the mammillary body. This is a massa intermediaris. It joins between the two thalamus. This is the anterior commission, which has been shown with relationship with the anterior to the third ventricle. Thus, this is the part of vascular structure which is showing in relationship with superior to the third ventricle, the internal cerebral veins. And as you can see, posterior-inferior relationship of cerebral aqueduct, which opens into the fourth ventricle. Now, this is a diagram in which we are seeing from superiorly. In this diagram, as we can see that foramen of Monro of both lateral ventricles has been exposed. And this is the thalamus striate vein and choroid plexus. As we can see that thalamus is located laterally with the third ventricle, and the third ventricle, the body of the fornix lies superiorly to the third ventricle. Now, in this diagram, the body of fornix is dissected to show the roof and structure of the velum interpositum in the past, in which we can see that the tilia choroidea, internal cerebral veins, and medial choroidal arteries. And also in this diagram, we can see choroid plexus as well. This is another diagram which is showing choroid plexus, internal cerebral vein, a better view, and medial posterior choroidal arteries. Now the roof of the third ventricle is dissected, and we can see that the floor of third ventricle in this diagram. This is the massa intermediaris, as we can see, and anteriorly we can see that the both foramen of Monro open at superior anterior into the third ventricle. Now, in relationship with the posterior part of the third ventricle, as we can see that the part of corpus callosum lie, and the splenium, which is a part of corpus callosum, lie at posteriorly to the third ventricle. The vein of Galen and the rosental vein joined to form the internal cerebral veins, and the pineal gland is relationship with the posterior part of the third ventricle, habenar commission, as you can see, and pineal recess. And this is the posterior commission as just shown. This diagram. This is another diagram which is showing the relationship of the third ventricle with massa intermediaris and our two vascular structure of velum intrapositum, the tilia choroidea, which consist of internal cerebral veins and medial choroidal arteries. And at the posterior part, at the inferior part, we can see the mammillaris bodies in this diagram. Now, Dr. Ariba will discuss regarding the approaches.
Dr. Riba, are you with us?
Yes, sir. So from now on, just we did anatomy of the third ventricle. So we are going to look at few images of the approaches to third ventricle. So how do we approach third ventricle during surgery? There are different approaches, there are different methods of approaching the third ventricle. We can go transcortical, which as the name suggests, trans means across, and cortex, we are going to go through the cortex, which can be of any lobe that we will discuss later. We can go transcallosal, that is by the help of corpus callosum. We can go subfrontal, that is below the frontal lobe. We can go transsphenoidal, subtemporal, stereotactic. So these are 5 ways by which we can approach the third ventricle. So let's just briefly discuss each one of those, starting with the transcortical. So we approach the lateral ventricle and for third ventricle. It's only possible if there's a hydrocephalus, especially useful if the tumor extends from the third ventricle into one of the lateral ventricles, which is causing hydrocephalus, and then we can go transcortically. The risk of seizure is high in this approach because we are breaching the cortex, which is approximately 5%, and this is higher than the transcallosal approach. Transcallosal approach is basically preferred in the absence of hydrocephalus. We can go anterior or we can go posterior. Anterior transcallosal is good visualization of both walls of third ventricle, but there's a risk of bilateral fornicial damage, which can lead to memory impairments. When we go posterior transcallosal, it allows approach to the quadrigeminal plate or the pineal region, just like Amna described, that it is, these structures are present in the inferior wall and the posterior wall of the third ventricle. But there's a risk of damage to deep veins because just as we saw, there are many main cerebral veins, intercerebral veins, and thymostriate veins, structures that are important that are present posteriorly. Another approach is subfrontal. As the name suggests, sub means below, frontal. So basically we are going below the frontal lobe. It allows 4 different approaches that can be utilized. We can go subchiasmatic. We can go through the optico-carotid triangle. We can go through lamina terminalis, or we can go transsphenoidal. By subchiasmatic, it means we are going below the chiasm. We are entering from below the chiasm. So we make an approach between the optic nerve and optic chiasm. In optico-carotid, we approach to the triangle that is normally formed between the optic nerve and carotid artery and the ACA posteriorly. By lamina terminalis, we can go above the optic chiasm. As we just saw, lamina terminalis is present in the anterior wall of the third ventricle. We can go transsphenoidally, which requires removal of the tuberculum sella, planum sphenoidale, and anterior wall of the sella turcica. By this approach, we can enter through the base of the or the floor of the third ventricle. Other approaches are transsphenoidal alone, a subtemporal approach in which we are going to go from laterally below the temporal lobe. And we can always use a stereotactic approach in which we are using image guidance that is usually useful for the aspiration of colloid cyst. So just a diagram to summarize different approaches to the third ventricle, our center where we want to go. So we can go subtemporal, we can go transsphenoidal, we can go translamina terminalis, via the subfrontal or interhemispheric approach. We can go by perichiasmatic, we can go transformational, pyramidal anterior transcallosal, posterior transcallosal. We can go suboccipital transtentorial or infratentorial supracellular. These approaches are usually used for pineal lesion or the quadrigeminal plate tumors. So what is transcallosal approach? When we usually go for transcallosal approach with third ventricle, we usually make a U-shaped incision on the center around paramedian basically, and then we retract. And this U-shaped incision, we usually do a craniotomy of 3 to 4 centimeter. We retract the superior sagittal sinus medially, taking care, and then we go between the two hemispheres, between the in the fox. So the structure that we are going to encounter in this direction, this is our center, like we are going here, third ventricle ke region mein. So the structures we are going to encounter is we are going to open the fox, callosal marginal arteries, pericallosal artery will come in our way. Branches of ACA, we are going to retract those. Then we will have the corpus callosum. We have to go through this. This is transcallosal. Then we will find septum pellucidum and the two lateral ventricles on the two sides. And then later on, we can approach the third ventricle. Now, while we are approaching the third ventricle, there are certain points that we should take into care. Usually the cholestotomy will not exactly be midline and one of the lateral ventricles will be entered. You have to take great care to correctly identify which lateral ventricle has been entered, another potentially disorienting pitfall. For orientation, we must know that the choroid plexus pass forward in the choroidal fissure to the foramen of Monro, which is medial, where it converges with the thalamus-striate vein, approaching from a more lateral position in the groove between the thalamus and cortex. There's a very good diagram of this that Amna showed us. Let me go back to the diagram. So yeah, we can, as we can see, this is choroid plexus, and as we can see, this is thalamus-striate vein. So they both converge.
Ariba, your diagrams are, the PowerPoint slides are moving, and just fix to one slide and then explain.
Okay, sir.
Yeah.
So the septal vein and the caudal vein approach the foramen from anterior. And if there are colloid cysts, the foramen of Monro may be hard to recognize initially as it will be plugged with the cyst, which can resemble the ependymal lining of the ventricle, but on close inspection, it's usually slightly clear. Another possible pitfall upon incising the corpus callosum is entering a cavum septum pellucidum, which is present in some people. That the important
Ariba, sorry to interrupt. Just can you explain that point? How do you define which foramen of Monro, which lateral ventricle have you entered by looking at the orientation of the choroid plexus and the thalamus-striate vein? Because it's an important point.
Yes, sir. So, can we all see this picture diagram? So as we can see, we are viewing from above, and we can see the both foramen of Monro's. So the point to differentiate here is we look at the thalamus-striate vein. Thalamus-striate vein run on the lateral wall, lateral side, and the medial septal vein runs, as the name suggests, it's medial septal vein, so it's going to run on the medial wall. So the thalamus-striate vein runs laterally. So if we are seeing thalamus-striate vein on our right side, this means that we are on the patient's right ventricle. And if we are showing thalamus-striate vein laterally or on the left side, this means this is left foramen of Monro. So we look at the thalamus-striate vein. This vein, this is always present laterally.
And what will a septum cavum look like? I mean, we don't have a picture, but the septum cavum will be like, there will be two layers of septum pellucidum and you will be in between.
Yes. And then there are different variations of the that cavum septum pellucidum. It's not usually always present, but it can be present in some patients. I don't have a good diagram of that, but it's something I can draw it. It's something kind of like this, that when we go down, instead of the two ventricles, lateral ventricles joining, we have another space, a potential space between, and that is cavum septum pellucidum. Moving forward, so there are some alternative approaches to the third ventricle, like we just read. We can either go interphoneal or from lateral ventricle. What is interphoneal? As the name suggests, inter is between the two fornix. So we go above the body of fornix. We approach roof of the third ventricle, because as we studied that fornix is present in the roof of the third ventricle. It's well suited for lesions of the mid and posterior third ventricle. Crasotomy should be as close to midline as possible. Or we can also go from lateral ventricle through the foramen of Monro. It is possible usually when hydrocephalus is present, the foramen of Monro is usually dilated. So if the foramen is too small for adequate access to third ventricle, we can either return to the interphoneal approach, or we enlarge the foramen of Monro only if absolutely necessary. Of course, it is not advisable to do this, because if you are going to enlarge the foramen of Monro, we are going to damage the structures that are present on its walls. And as we just, Amna just told us that the foramen of Monro is mounted superiorly by the fornix, causing a memory impairment. We have choroid plexus there, we have important vessels there. So we either enlarge the foramen of Monro by opening the foramen laterally, the safe space, or we can go for a subchoroidal approach, making the incision posteriorly, sacrificing the thalamostriate vein, which is said to be well tolerated. In the last resort, when we can't do anything, we can incise the anterior superior margin of the foramen through the column of the fornix. Now, this is going to damage the fornix. If the other fornix is also non-functional for any reason, this would produce a bilateral fornicial lesion, and which may, but not definitely, will result in loss of short-term memory and ability of new learning, because as we know, fornix is involved in the memory. So this is what we were talking about. So this is the black hole that we can see is the foramen of Monro. As we can see, the superior wall is formed by the column of the fornix, and as we can appreciate, the laterally, the important structure, the safe space that just we can extend is laterally. If we are going to open the foramen of Monro, we can open it laterally. So the other transcortical approaches that can be used are through the middle temporal gyrus or the middle frontal gyrus. जी नहीं, we started with the transcallosal approach, and then we were discussing how can we actually enlarge the foramen. What are the alternative approaches if that is not functioning? So we can either go through the interphoneal approach, or we can extend the foramen Monro from lateral ventricle to third ventricle. So when we are doing that, usually it occurs when there is hydrocephalus and foramen Monro. Suprachoroidal then? Do you want to add something?
One is between the choroid plexus and the column of point, other is between the choroid plexus and the thalamus. So when you are separating the choroid plexus and thalamus, I think this one is the suprachoroidal, and the subchoroidal is in the separating the choroid plexus and thalamus. So these two approaches are. वो दिखाते हैं, किसलिए दिखाते हैं? This one.
कौन सी वाली?
I think Yasir तुमने पढ़ाया था ना, तो practitioner से जाते हैं हम determine. Basically, it is from lateral into then lateral and then access to the third. So you can go via foramen of Monro, you can go interfornicial, or you can actually dissect the level of the choroidal fissure. The choroid choroidal fissure is found between which two center?
यहाँ पे वापस थैलेमस और सब थर्ड वेंट्रिकल की हाँ फॉर्निक्स के बीच में फॉर्निक्स से
You are separating the choroidal fissure on the side of fondix. You are separating the choroidal fissure on the side of the thalamus.
so अगर like if you're going to do it here suprachoroidal
Dr. Reba,
yes sir
whoever doctor, can you tell Dr. Yasser to just highlight the point that he wants to make and use the mic while doing it, so that those who are listening online can understand what he's talking about. So just make the point that he wants to make and move on. Yeah, sir.
Yes, sir.
So,
I was just talking about
just make the point.
The approaches that she was just describing. So you can see that. So you can see that this is the foramen of Monro. Here we have the fornix. So we can go via interfornicial approach, or we can go via the choroidal fissure. So when we are going via the choroidal fissure, or from where the choroidal plexus is basically attached to the body of the fornix on one side, and on the other side it's attached to the thalamus. So we can either detach the choroidal plexus from the tinea fimbriae of the fornix, or we can detach the choroidal plexus from the thalamus. So depending on this, we have got a suprachoroidal or a subchoroidal approach. This one will be suprachoroidal, and on the side of the thalamus, if we are detaching it, would be a subchoroidal approach. So that's what I was just telling.
Okay, and can you tell us what the choroidal point is? Where the
choroidal point is?
Choroidal point.
Basically, the correct
surface head point आप बता ना.
Basically, ये बता देना. Basically, the correct axis in this picture. So you have to decide dissect the correct axis from this picture, and you have to open the fissure. Then in this picture, you have to enter into the
third ventricle.
Because this is safe area, safe entry point.
So basically, what we are discussing is the choroidal approach, and what Dr. Yasser just mentioned is either you separate the choroidal plexus from the thalamus, and so there's a
Yes.
suprachoroidal and infrachoroidal approaches, or so there's one way of extending your approach to the foramen of Monro, or you can go into fornicial. Is there anything you want to add, Dr. Yasser?
No, sir.
No sir.
Dr. Reba, move on, please.
So just as we discussed, the transcortical approaches can also be made, and these are through the cortex. So there's always a risk of seizure, which is around 5%. So the approaches that can be used are either we can go through the middle temporal gyrus, or we can go through the middle frontal gyrus. When we go through the middle temporal gyrus, it's useful when temporal horn of the lateral ventricle is dilated due to hydrocephalus caused by the tumor, and access is through the temporal horn, then into the ventricular system. When we are using the middle frontal gyrus approach, we make a 4 centimeter incision parallel to the axis of the middle frontal gyrus above and anterior to the expressive speech area, that is Broca's area, which is usually present in the pars triangularis and or opercularis, and anterior to the motor strip about the same point as that we use for a frontal ventriculostomy. So these are the two approaches of transcortical. Just to summarize, the approaches to third ventricle, we can go subtemporally, we can go transsphenoidally, we can go through translaminar terminalis via subfrontal interhemispheric approach. We can go through the anterior transcallosal or posterior transcallosal approach, and there is negligible risk of seizure through this approach. Or we can go through transcortical approach. We can go through middle temporal gyrus, middle frontal gyrus. We can go through the infratentorial supracerebellar approach, which is usually used for the posterior and pineal region tumors. And we can also go for suboccipital transtentorial approaches.
The rest can add up as well. We have a question from Dr. Mehboob, and he says, which vein can you sacrifice during ETV? I mean, ideally, while doing an ETV, there's hydrocephalus, and the foramen of Monro is large enough that you don't need to sacrifice any vein. So if you sacrifice the thalamus vein, Dr. Reba, what do you think will happen? Yasir? Can you please hand it over
Usually
the
it's well
mic?
tolerated.
Sorry?
So usually, as per the text, we just read that it's well tolerated. But if the deficits were to occur, we could have the deficit of the region that is just draining. So it's draining the thalamus and the adjacent striatum. We couldn't have a venous infarct of that region, but this doesn't usually occur because of the additional drainage that we have. So if we were to
And
have
so
an infarct, it would be of the thalamus and striatum venous infarct probably.
and same for the medial septal vein?
The medial septal vein I do not know of, sir. If you can add, it's
So
usually draining the septum
so
pellucidum.
so it's very rare that you have to sacrifice the vein. I mean, normally if you're doing an interchoroidal approach, maybe, but if you're just doing an ETV, and if the foramen motor is large enough, I mean, you can just, I mean, it gives you that corridor to just go forward and do an ETV. So if you have to sacrifice a vein during an ETV, that means maybe you're not maybe you're not the patient selection is not right in terms of ETV, because one thing that we do look at is the diameter of foramen Monro while we're doing ETVs. So yeah, as Dr. Yasir said, due to collaterals, it is tolerable, but it's I think for a procedure like ETV, sacrificing any vein is not recommended. Um, Dr. Man, would you like to add something to it?
Sir, basically you are talking about the choroidal approach.
No, there was a question, and the question was, can you sacrifice any vein while doing an ETV? Can you can you sacrifice
No,
thalamus
sir.
vein?
No, sir. Sir, I agree with you, sir. It's basically you have to preserve all the veins, all this. I agree with you. It's advisable not to take any veins in this region.
So if there's any questions from anyone, those who are online can use the chat box. Others who are available in the conference room can maybe use the mic. Can use the mic. So it was a good presentation on part of Dr. Amna, and followed up with follow up with the approaches. And normally, while we approach the third ventricle, the normal route that we usually take is either the transcortical via microscope or an endoscope, or sometimes the transcallosal approach. It's very rare that we have to do an interchoroidal or interphalangeal approach, but it is an adjunct that you can add to your surgery just to extend the foramen Monro, or avoid injury to the fornix. So what will we discuss next week? Will we be discussing fourth ventricle, Dr. Riba?
Fourth ventricle. Next, inshallah, we will discuss anatomy of fourth ventricle.
And Dr. Amna will be presenting fourth ventricle.
Yes, sir.
Yes, Dr. Amna will present it.
And who will present the clinical side, the clinical approaches to the approaches to the fourth ventricle, with maybe a scan as well?
Priyanka. Dr.
Okay.
Priyanka will present the clinical side of the fourth anatomy, fourth ventricle.
Thank you everyone for coming. Thank you, Dr. Amna, for the presentation, and thank you, Dr. Riba, for the approaches. We'll see you all next week. Take care of yourself. Thank you, everyone.
Thank you, sir.
Thank you.
Rather than translate.
तुम ट्रेनिंग करवा के चले गए थे